All right, welcome back everyone to another virtual shadowing session at Hearts for Health today. We're going to be joined by Dr. Barrett. We've been looking forward to this session. We have a lot of people who are looking forward to this session, especially being that it is in neurology. So we're very excited to have Dr. Barrett on with us today. Dr. Barrett, just a little background about her. She's the Neurorehabilitation Division Program Director at the Emory Brain Health Center and serves as the Executive Director of the Center for Visual and Neurocognitive Rehabilitation at the Atlanta VA Health System. As a few reminders to those who might be new to virtual shadowing or to our program specifically, towards the end of each of these sessions, we will have a Q&A. So at the very end of the last, let's say 15, 20 minutes of the hour, we're going to have a Q&A, and you can feel free to type in your questions in the chat box. Once we get around to that time of the session, I will read them out to Dr. Barrett and she will answer them. So if you have any questions, feel free to type them in, whether it be now, in the middle of the session, or even during the Q&A. We're happy to take any questions. Also, for those who want to stay tuned with more shadowing sessions, we go by a Monday and Thursday schedule, usually at 7 p.m. Central, but sometimes times do vary, which is why you want to keep your eyes peeled and tune in for exactly the timings and the days that we do have them. Also, there's many specialties and speakers. Since the summer, we've expanded to include not only medicine, but also dentistry and PA speakers. So with that said, if you're interested in a particular speaker, you're able to be kept in the loop by either following us on Instagram, where we post our flyers, or you can join us on our email listserv, where we also post our flyers, although it's over email on a weekly basis, and sometimes we'll include some other opportunities. We have a few other programs outside of virtual shadowing, so you'll get some word over that via the listserv. To join the listserv, you can either subscribe on our website, which is available via subscription form at the very bottom of our page, on any page of the website, or just email us. Our email is shadowing.h4h@gmail.com. Just send us over your name and your email, your preferred email address, preferably a personal email like a Gmail or Yahoo account, because otherwise school emails usually filter out, and you'll be able to get those listserv emails to stay in the loop. If you have any other questions for us, feel free to reach out, but I don't want to take too much time, so Dr. Barrett, feel free to take it away.
All right, well, it's excuse me, it's a great pleasure to be with you all tonight, and thank you all for being so interested in neurology. Excuse me, just didn't want to be too froggy for you guys. I'm going to be talking about a little bit about my career path and how I went into medicine, and my choices kind of in what I'm doing in neurology. And then we're going to kind of, since we can't actually put on our white coats and go into the hospital, one of the two hospitals where I work, and talk to some of the people who have some of the disorders that I'm particularly interested in, we're going to kind of review them in our slides, and we'll have a chance to, talk about some of the complex, but I think fascinating problems that they have. And I'm going to stop a couple times during the presentation so that if people have kind of questions as we go along, I can address some of them so that people, if they feel like they're really a burning question. The one thing I want to mention, which oftentimes people at the undergraduate level are wondering about, is that there are medical specialties and surgical specialties, and neurology is a medical specialty. So our colleagues, neurosurgeons, do surgery on the brain or the spinal cord or the peripheral nerves. Neurologists do medical interventions, so they assess, diagnose, and treat and manage neurological problems of the brain, spinal cord, peripheral nerves, muscles. So we'll talk about that, but one of the things I want to highlight in this first slide, which shows a picture drawn by one of my patients, and we'll talk a lot more about why that person drew that picture in that way. There's also some letters after my name, and one of those relate to my being, kind of very committed to certain organizations. So the first one is the American Academy of Neurology. And the American Academy of Neurology actually is quite interested in engaging people who are learners at the high school and college level. So feel free to check out the American Academy of Neurology online, and you probably will find some resources on the website that might be of interest to you. But basically the other two organizations are the American Neurologic Association and the American Society for Neurorehab, because those are my two areas, is what's called cognitive neurology within neurology. So neurology is a specialty. This is called a subspecialty. And then my other subspecialty, because one wasn't enough, is neurorehabilitation, neurological rehabilitation. So let's talk a little bit about what I did, before I was a doctor. But first, whenever doctors give talks, we always need to kind of make sure that you all know where the information we're presenting comes from. And I do get some honoraria, but you don't have to worry about this talk being financially motivated, because they're not related directly to what we're going to talk about. And these are my employers that Michael already mentioned. The stuff that I'm going to present that relates to my work is not my work alone. And certainly there are a lot of collaborators and partners I've had in that work, but there have also been, the federal government and many of its agencies, and then private organizations. And those of you whose families or who themselves are taxpayers have contributed to my work. So I thank you for that. And so these are some of the people I would thank. So I'm originally a Midwesterner, born in Northern Indiana in South Bend. And I was interested in science from an early age, but I didn't necessarily want to go into medicine. I'm not one of these people. There are other doctors in my family, but neither of my parents are doctors. And when I was in college, I really thought I would probably be some kind of a psychological scientist. And I worked for a scientist who's a pretty famous guy, Stephen Kosslyn. It was a great experience as a psychology major in college. And at that time, Steve and a number of other people were getting very interested in how the brain supported what are called cognitive operations. So operations that support specific kind of stage-wise processing of thinking and mental function. And that was really exciting. So they were doing some stuff like looking at how did it affect the brain if certain regions of connections between the right and left hemisphere of the brain, for example, if people had an operation that cut off those interactions. It was a very, very interesting time. And technologies such as brain imaging were really taking off, and things that we can do now easily to see parts of the brain, they were just becoming kind of available at that time. So it was a really cool time to being involved in brain-based activities. And that was where I entered the VA, was right after college. I worked as a research assistant, and then I applied for college after I graduated, or I applied for medical school after I graduated. I wanted to think it over. Actually, I hadn't really decided at the time when I graduated college that I wanted to be a doctor, as I mentioned to you all. And it was probably my experience that I had in that in-between time when I had the opportunity to watch doctors in the Boston VA area at the Jamaica Plain Hospital, actually, and interviewing patients, analyzing what was going on with those people, most of whom had had strokes. And actually what I do today is quite similar in some ways to the inspiration that I got at that time. And that's really kind of where I got very excited about the VA. And although the veterans that we were seeing then were quite different from the veterans now in terms of their, cohort, their age, and the conflicts that they were fighting in, it's a great system. And one of the things I hope you might remember from this is that the VA is a great place to be a doctor for so many reasons. And, I did my training, my medical school training at NYU. And that's a terrific medical school, as many of you know. It was terrific even then. So even though I've alluded to how long ago it was when I went to medical school, very, very, very long ago. And one of the things I joke about is that I always joke, oh, back then we would write our notes with a chisel and a hammer. But actually at NYU, they already had an electronic medical record more than 25 years ago. So NYU is a great place. I can't say enough good about it. And I had the opportunity to see patients or to be involved in the in education about patients, both in the university hospital setting, which was great, and then also at Bellevue, which is a world famous hospital and a terrific, terrific place with world-class care. I did my internship, interestingly, after graduating from NYU at a community hospital in Connecticut that was affiliated at that time with Yale. And that was also a great experience because I learned about, I'd been kind of in this academic system and then in this public hospital setting. And then I was in a private community hospital, and things were done very differently in those three settings. And I learned a lot about how did doctors really function in the community, because most of the doctors I met in that hospital were private practitioners rather than being, teachers or researchers. And then I went back into academia for a few years at the Neurologic Institute in Columbia, again in New York City. And it's up in Washington Heights. I love it up there. Really cool place. And I was there for 3 years. And we'll talk more about, what I learned in neurology. However, as I mentioned when I was joking about having 2 subspecialties, I'm just one of these people can't get enough of learning about stuff. So after I finished my neurology residency, I did a fellowship. But really the reason why I did that was, if you remember, when I started off as a psych major in college, I wanted to do research. I kind of was interested in learning about, why did the brain do certain things, or why did our minds do certain things? And when you go into medicine, much of your time is spent kind of practicing the procedures and tasks that physicians need to do and really getting good at those tasks. And so you lose the time that you might have spent otherwise, doing your own research and publishing papers about your own research, developing your own ideas. So postdoctoral fellowship or a fellowship time after you finish your residency is oftentimes a great thing for physicians to do. So I spent 2 more years, and I was in Gainesville, Florida, which was a terrific place also. And, I guess something that people asked me a lot when I was at NYU, because NYU at the time when I was there, and it still kind of emphasizes this, was a place where where it was emphasized to go into internal medicine. And so I got a really great internal medicine background. I worked with a lot of people who were very, very serious about internal medicine. At that time, inpatient medicine was kind of equally emphasized to outpatient medicine. Now, I think rightly, outpatient medicine, community medicine is more emphasized. But at any rate, people were like, why do you want to do that? And I think that what was unappreciated were 2 things. And one thing is that neurology is actually part of medicine. So people who have diabetes, for example, regularly have issues with numbness in their feet and pains in their feet that are caused by the nerves in the nerves being affected by the diabetes, because the blood vessels that provide to the nutrients to the nerves are affected by diabetes. A number of other disorders are regularly accompanied by problems, neurological problems. So, I mean, an obvious one is high blood pressure and stroke, which I'm quite interested in stroke. Almost all my patients also have high blood pressure. So it's quite common to have neurologic problems as part of a whole patient picture. So I think that that's one reason, if I had known about that 30% kind of figure, I would probably have said that to my colleagues in medical school. The other thing is that I think that I mentioned here is neurology is really kind of fun and complex. If you enjoy solving problems, if you're the kind of person who, like me, like people love to bring me, in my family, people bring me, like if they have a necklace and it's all wound up, they'll bring it to me and ask me, and I'll spend 15 minutes and unwind the whole necklace, because I enjoy that kind of activity. I enjoy solving problems and working things out. And neurology is definitely an area where if you're patient and you look at patterns, you can definitely solve problems that are complicated. And aphasia is acquired speech and language problems after usually a brain injury to the left brain. A complex problem. A lot of people feel that if somebody has aphasia, that person has an intellectual issue, for example, but it's not an intellectual issue. It's kind of like being in a land of people who speak another language, but the intellect of the person who has aphasia is often not affected. Spatial neglect is the problem that I study, and it's defined by asymmetric behavior. So the right brain, which is our spatial hemisphere, people sometimes think it's kind of the artistic or intuitive hemisphere, but one of the things it's dominant for is visual spatial behavior. And when it's damaged, our visual spatial world becomes unbalanced. So that's one problem that is complex that I study. And then I study a number of other kinds of issues like memory disorders, skilled learned movement problems, recognition problems. And I'm trained in, as I mentioned, what's called cognitive neurology. So I can evaluate when people have different forms of the syndrome that's called dementia, which means that people have a cognitive problem in more than one area. So they may have speech and language and memory, for example. And usually those people have problems where the brain cells can't make enough energy. And so then the brain cells begin to degenerate. And people ask me oftentimes why I do research, but usually those are not people who know me very well, because again, I just love to solve problems and I love to really think about things in a complex way. And, research really was what I always wanted to do. I was just fascinated by it when I got into college. I loved reading research papers and writing about research papers. And when I was in college, I did decide to do pre-med. And I think looking back, I'm not sure why I did that, but I think that really I wanted more options. But it was one of the best decisions I ever made to do pre-med courses, because even though, as you guys know, probably doing that right now, it may seem like if you want to be a doctor and be with patients, it may seem like it's, we're studying biochemistry or studying physics isn't kind of on point. At the same time, it really allowed me to do, once I was done with that, and once I left college, I had so many more options. And being basically, I think one of the big advantages of being a doctor over being and being a nurse has this same advantage probably. There are some other professions that I think allow a little bit less variability in scope, but there are so many different things you can do. And I think what I enjoy is the balance of doing things that provide a short-term reward and a long-term reward. So, and vice versa, short-term challenges and long-term challenges. So if I, for example, in being a doctor, in working with people, patients, oftentimes, there's conflicts or problems. And that can be very frustrating to deal with. But if I'm working on a research project and I invest time and effort, that's a more dependable, in general, it's more dependable payoff. And eventually I'll be able to publish, let's say, a paper, and other people will tell me, wow, I love that paper. But that takes, several years for all of that to happen. So it can kind of balance those things. And then the other thing that's funny is that I think being somebody who's really interested in details, and I'm trying to remember if people were called nerdy when I was young, but they probably were. And I was very nerdy. And so I always thought I was an introvert, and I'm really not at all an introvert. I'm really extroverted. And being a doctor allows me to just get, what I need. I'm able to interact with people and learn about people, and I can ask them questions. I love, one of my favorite things as a neurologist is picturing what the person that I'm seeing, who usually has a neurological issue, what they were like when they were young or when they were completely healthy. And I'll ask them, what kind of work did you do before you retired? What did you like about that work? Sometimes I'll try to guess, or I'll try to ask questions about it, and I'll ask them to explain it to me in terms that, simple terms, please, because I wouldn't understand. And it's just a delight for me to get that contact with people. And then I guess also something I really enjoy about medicine, and I don't want to make this too, it's a two-sided thing. I don't want to make it sound like doctors have a better moral character, because clearly that's not true. If you find out things about, people are people. At the same time, what's great is the medical profession. And, in some, for example, in working for the VA, I really enjoy this. It's people are there for a reason. And oftentimes we, we can exercise kind of our core value together. And so I find that I can enjoy my relationships. And I also find, having worked in a number of different settings, and I've worked in some settings where I was working around a lot, mostly my colleagues were mostly business people or lawyers. And I'm not saying that it's necessarily a problem that people might have kind of a work persona or a negotiating persona or another persona, but doctors as a group oftentimes just kind of let it all hang out and they act from their basic personality. And that's an issue, I think, in that some doctors can be kind of naive about certain things like negotiating or like, financial issues, that supposedly doctors are some of the people who can benefit most from financial counseling and knowledge and learning. But it actually is really great for me to be able to bring myself to work every day and not worry a lot about kind of every aspect of communication. So that's not really about research, but it's more about kind of research and medicine. And I think what I'm kind of getting at is, I want you all to bear in mind that although it feels like you're preparing and preparing and preparing, and you're going to get to a place, what actually happens to us, and I'm really grateful for this, is that we continue to grow and change as we go through life. And at every stage of life, we find our new stage that we want to be in. And there's a really terrific book called The Second Career I believe it's by McDonald Critchley. But most people, one of my former teachers, a neurologist named David Good, used to say that most people want to do something a little bit different every 10 years or so. And so really think about that, as you plan your career. And that's, I think, one of the reasons I'm so grateful I went to medical school rather than pursuing graduate school, because I think that lots of people remake themselves, and more power to them. I think I needed to have kind of a more general training in order to find, the opportunity to do almost all research at one point, and then almost all clinical care at another point, and then almost all, and I'm now doing a mixture of those, but administrative work also. So I started off at the University of Florida, as I mentioned. I did my fellowship there, and then I was there as a kind of a baby attending, I guess you'd say. I had kind of a temporary appointment there for 2 years. And then my first faculty appointment was at Hershey Medical Center, a terrific, terrific place in central Pennsylvania. And then I was for 15 years, actually, in the Rutgers system at Kessler Institute for Rehabilitation, which is the largest inpatient rehabilitation hospital in the country. It's actually 4 different hospitals in New Jersey. And I also worked for Kessler Foundation at that time. And now, since 2019, I've been here at the Atlanta VA, here in Atlanta at the Atlanta VA, and also at the Emory University School of Medicine in my different roles. So it's really fun, I think, working in different places and kind of finding the commonalities of that. So I guess I'll pause for a second there and see if there have been questions about that. And then we'll kind of go to the virtual bedside of a complicated patient. And I actually have 2 stroke survivors who were willing to share their stories with you. And it's interesting. Usually people start with the easy one and then go to the more complicated one. But I thought we'd start with the complicated one, because in real life, if you were shadowing me, we don't know what's going to come next and what's going to come through the door. So sometimes the most complicated thing is what we see first.
Well,
Are there any questions at this point about kind of training or background?
I wanted to go through one quick question.
Yeah.
And that is about just neurology as a specialty. Like you said, there are subspecialties to it, and as a specialty, it's like pretty broad. There are things that you can look into specifically. But having said that, it likely relates a lot to the rest of the body, right? It's very connected. The body is a system. So with that said, being a neurologist and going through cases day to day, does it really require you to expand your knowledge and exercise the knowledge you have of other areas of the body? How do you see neurology connecting with other specialties, really?
Oh, yeah. I mean, well, as I mentioned, medicine and neurology are really intimately linked. But neurology was actually at first a sister specialty, or the same specialty as psychiatry. So they're obviously also very closely linked specialties. And at NYU, when I was a medical student, psychiatry was a really emphasized specialty, almost as much as internal medicine. I was really strongly encouraged to go into psychiatry. And my husband always jokes that almost all my friends are psychiatrists, which is really true. However, I just was always interested in problems of, I was interested in behavior issues, but I was interested in issues that weren't very variable. And the thing that was, to me, I thought too complicated, or something that I didn't feel kind of the confidence that I could move forward on and really feel passionate about, was that people who have psychiatric issues have a lot of variability, and that the things that we would notice that were characteristic and helped us to make a diagnosis might be only present 5% of the time or 10% of the time in psychiatry. But of course, in psychiatry and neurology, or the type of neurology I study, which is based in brain stuff, the brain systems are what may produce the issue, at hand. And I think pediatric developmental clinical care, and of course, pediatric neurology. But many people are developmental pediatricians, and that clearly also relies on and is very closely related to what happens in neurology. There are a number of other specialties that are very closely related. Obviously, neurosurgery and neurology are kind of sister specialties, in which mostly people come to a neurologist before they would come to a neurosurgeon, and then the neurologist might follow them along. So, for example, somebody might have, seizures as a symptom of having, let's say, a benign tumor that then has to be removed by a neurosurgeon, but then they go back to their seizure epileptologist, their neurologist who specializes in seizures, and that person continues to see them. So yeah, I mean, that's, I think, something that I love about neurology, is there is an opportunity to learn a lot about other specialties. It does become, at some point, because the field of neurology is so vast, you can at some point kind of accumulate, and it is also what we say very empirical, very dependent on experience. And so you can kind of grow expertise by doing in neurology. The thing that kind of is frustrating for me at this point in my career is that the other specialties I haven't necessarily been doing. So, and also things move forward really fast. I'm like, what is this medication? What is this? I don't even know sometimes. Oh, there's a medication now for that, So, I have to continually learn from my colleagues and read up. And that's one of the reasons why when people go to medical school and complete their medical degree and then become practicing doctors, license bureaus, hospitals in the States will require that you do a certain amount of continuing education. And it's just absolutely necessary, especially for subspecialists, because as you say, we have to keep up on, what is that hypertension medicine? What is that antidepressant? What are those other, what is that disorder? Because there are many disorders that weren't named or didn't exist the way that they are now when I was training.
Absolutely. Another question for you, and we'll maybe bounce back to the presentation and carry on for the rest of the questions at the Q&A. But one more question I wanted to mention was from a student who asks, what's the most interesting project that you've taken on, being, I think that they're referring to the research.
Sure. We're going to have a chance to hear about that.
Okay.
I wove it in with the cases. So the first patient will talk a little bit about that, but I'll try to remember to talk about why it's interesting if I can.
All right.
All right, so let's talk a little bit about, let's pretend we've come to the bedside. As I mentioned, I was at Kessler Institute. So any of you all who are in New Jersey might know of Kessler Institute. It's up on a hill. The one in West Orange is up on a hill, and you kind of have to take this winding road to get up there. We've all driven up, and we're walking to the bedside of somebody who's having what's called inpatient rehabilitation. So that person, it's a kind of a cheerful hospital full of healing, and not like a, the typical hospital where people are running to codes and this kind of thing, but a hospital where people are singing in the day room, playing piano, really a different kind of environment than acute care oftentimes. And the person we come to meet has had a stroke, and his stroke, let's see, my thing here is in my way, was related to occlusion of the carotid artery here. So he had, he had atherosclerosis, arteriosclerosis, and probably, related to hypertension, high cholesterol. He also has diabetes. So the wall of the artery got very thick and developed, a clot developed there. And then eventually there could be no blood flowing through there to the middle cerebral artery, which perfuses the brain. He also has some issues with neuropathy, which we talked about before. And unfortunately, when his carotid artery here finally closed and the blood stopped flowing, a part of his brain that was affected here is called the motor region, primary motor region, and it caused there to be a paralysis on the left side. So we can call that paresis if it's partial, or plegia if it's complete. So he's unable to move his arm. And he has this problem called spatial neglect. So that's the area where I've done research, and we'll talk more about the specific research that I've done. But now he's been to a stroke unit in a local hospital. He's received, treatment there. He was in an ICU, let's say, for a while, and then he was discharged from that hospital. And now after 2 weeks, he's still in an inpatient setting in rehabilitation. There he has again, this paralysis that affects his arm, and his shoulder joint is what we call subluxed. So it's kind of drooping in the shoulder. What the orthopedic doctors will tell you is that the shoulder is a joint that's held together by its musculature. So when the muscles become more lax, the shoulder joint itself kind of starts to sag. And part of what creates that problem is a tightening of the muscles that happens when the brain input is not being received, and that's called spasticity. And unfortunately, this person has a lot of pain, and he tells us that his pain is aching and squeezing, burning, and twisting. But something that's odd and interesting about the pain that he's experiencing is he keeps saying it's in the shoulder, but he doesn't point to his shoulder. He points to his foot or his hip or his arm. However, when you move his left plegic arm, remember, he can't move it at all. That's where he winces. He doesn't wince if you move his leg. And what people have been tell you is, the nurses tell you, is that at times he doesn't seem to be completely with us. So sometimes he doesn't seem to be able to pay attention continuously to what's going on and gets distracted. That sometimes things fluctuate. So, some of you may have heard this term sundowning, so that at night, some people kind of get confused or cry out and they're fine during the day. And then this disorganized thinking. So one example of disorganized thinking is people may think that that it's a different time than it is. And usually, pretty much always, it's a time in the past that they think it might be. So he's receiving some care from our rehab doctor colleagues. He's receiving some botulinum toxin, which of course is a deadly infection, but it also can be used for spasticity or tight muscles to the left shoulder. And that's relieved some of the tightness so that the shoulder can be moved, but it doesn't help with movement, obviously. And they're giving him some codeine around the clock, and also a medication for neuropathy, because they felt that perhaps that that was producing some of the pain that he has. But what we'll talk about is that, so this is actually not the person who gave his permission to be for us to discuss him today, but this is actually Roy Horn from Siegfried and Roy, who we lost recently, unfortunately, during COVID. And Roy Horn had a similar kind of problem where his internal carotid artery flow stopped, and he had a stroke, and he developed this issue, spatial neglect. And what you can see that's interesting, you can see that he has weakness on the left side of his face. That's called a left facial palsy. That's not part of spatial neglect. But you see that he's not looking straight ahead. He's kind of looking off to one side. So whenever we see what's called pathologically asymmetric behavior. We know that it's possible somebody might have spatial neglect. And the other two things we can see in this picture is he's put on his eyeglasses a little bit wrong. So there's a YouTube video I'll draw your attention to later that I've done in the past, but where I've talked about spatial neglect. But what I talk about in that YouTube video is that the right brain doesn't just help us with vision, it helps us with all kinds of spatial function. So putting our glasses on our face is kind of a spatial task. And so we have to reach far enough to the left to make that happen. And if we don't reach properly to the left, what's going to happen is that the glasses are going to be too high on the left side. And that's exactly what's happening to him here. Okay, and you can also see that he's put on his tie himself. He wasn't able to figure out the tie and the collar here on the left side, his spread collar, I believe it's called. So what is this problem, spatial neglect? And here again is this thing called this hanging eyeglasses sign. And my friend Victor Mark at the University of Alabama at Birmingham published this description. Again, it's asymmetric spatial behavior. So this is where my kind of research interests and my kind of curiosity about solving problems came together. And it always has to be more than just the movement abnormality. So if you can't move your left arm because it's paralyzed, that's not spatial neglect. But if you're able to move the left arm, but you're disinclined to do so, then that is potentially related to spatial neglect. Or if you're able to see, but you cannot, understand or are unaware, that's also related to spatial neglect. And I and my colleagues have defined it by functional disability. So here, for example, somebody wasn't able to complete what's called an activity of daily living, of shaving. So he's able to shave on his right side. He's had a right brain stroke, but not able to shave the left side of his face. And here I just put I put a YouTube clip for the last time that Siegfried and Roy performed on stage. And in this particular clip, there's quite few clips you can find on YouTube of this last performance of Siegfried and Roy. I think it happened in 2010. But you can see in that very short performance that he's able to move, he's able to walk, but he is unable to move leftward. He is able to walk rightward. He has to actually be led leftward. So he has a pathologically asymmetric behavior. And in animals, what you actually see is that the animals turn spontaneously, and as a symptom of this spatial neglect. And it's a hidden disability. So when we're talking about this turning behavior, maybe you all can kind of see the turning in these people's behavior, even though we're looking at a static picture. This is a person rolling her wheelchair. And we could easily, if all of us were in Kessler Institute now, walking down one of the hallways doing rounds, we could easily be seeing somebody wheeling her or his wheelchair in that way. And oftentimes, not only would their body be turned, but they would actually be turning the wheelchair to the right. And sometimes I've seen people kind of make circles if they were not assisted. The way that wheelchairs work, if you're just wheeling with one hand, it may go actually to the left too, depending on where you kind of put your effort. But oftentimes they might go to the right or to the left pathologically. So this turning behavior. And it's unfortunately a hidden disability. So when we see people with this, it seems like it would be so obvious, this turning behavior. And in this person, Victor Mark reported that just like the patient that we kind of just virtually saw on our rounds, he had a lot of pain in his neck and required a lot of pain medication in his neck because of this turning behavior. Most of these people are missed, but I can almost guarantee you all that if you go into medicine, whether it's as a doctor, a nurse, a PA, as an allied health professional in rehabilitation, you will meet somebody with this disorder because it's so common. And most people, you might be the only person, interestingly, who could diagnose this problem. When you see this turning behavior, it's almost always spatial neglect. Because about half of people after stroke have this problem, and it does resolve to some extent after a year or two in most people, but not all. And so there are many people that I have seen in my clinics who several years 5 years, 6 years after stroke still have very severe spatial neglect. And as we mentioned, they have an increased risk of pain syndromes, but also a risk of falls. Obviously, if you're turning like this, you're not going to be able to be as stable. They have an increased risk of becoming delirious, as we saw in the person that we rounded on. And then if they're taking medications, so this person was taking codeine, for example, their neglect can actually get worse because the right brain kind of is trying to regain some of its network function, and pain medicines actually reduce the ability of the brain to be active. But this is some of the stuff that as you go to medical school, you'll be told to do to diagnose spatial neglect. And the reason I didn't start with that is I don't think it's as useful, because the other behaviors, I'll tell you that on my first rotation as a medical student in OBGYN, I saw that turning behavior and I was like, wow, look at that. And I think I asked my resident physician and she said, oh yeah, that's the CVA, that's the stroke causes that. But she didn't, give it a name or talk about the specifics. So it's definitely something I think that many, many clinicians would notice. Whereas if you wanted to do this task, and this is a task called the Albert task, where you make little chicken scratches on a piece of paper and ask the patient to cross them out. And this is a person with right brain stroke. They might omit some of the crosses on the left, but it takes a long time to do this test. You could do it, and it's good to do it. And it takes a long time. This is actually one of the reasons that's good to do this test is in a study that was done in the 90s. It was actually a better predictor of whether people could live independently than paralysis. So spatial neglect is really important. But here's some kind of more classical examples of spatial neglect when somebody's trying to copy a drawing and they're not copying the left side, so they're not aware of the left side. We're going to go back to the other drawing with the line, but something I just want to emphasize again, I think that, this goes right back, Michael, to what you were talking about. We oftentimes think about things like addiction or pain as being problems that are separate from neurology, but of course, this is very intimately interwoven. And unfortunately, something that was talked about and that Roy Horn talked about before he died was his difficulty with pain medications that he had become dependent upon, and his difficulty in reducing those doses and managing that, given that he really had a lot of pain. So, it's really a true issue for these people. And if we were rounding, we probably would talk to the team, where would we want to balance the pain medication? And what's kind of interesting about this problem delirium that we were talking about is it can actually be caused by pain as much as it's caused by pain medicine. So we have to make sure that, pain medicines are not always the bad guys. Sometimes we want to use enough pain medicine to make sure the person's not in pain, because the pain could itself be causing delirium, be causing confusion. Okay, so now to the research thing that I was interested in the about 2005-2006 period, a treatment for spatial neglect, Prism adaptation therapy, actually it's called, became available. And this treatment involves wearing off-the-shelf optical prisms and making repeated movements. And what we have people do is we have them just cross out a circle or mark the middle of a line. And what this therapy can do is actually improve spatial neglect. So if people are interested, there's a YouTube video called A Vision of Brain Injury Rehabilitation. So this patient could receive Prism adaptation therapy. And what's kind of interesting is it might not just help it might help spatial neglect, but it might also help the pain. There's some small studies showing that it might help the pain. And this, I'm going to kind of go past this. This is basically just a graph that shows that Prism adaptation therapy can not only improve how people do in the laboratory, but it can also help things like activities of daily living and navigation and reading and writing. And we won't go over kind of the detail of this, because I know we're getting close to a quarter of. This is the second person that we're going to meet, and let's pretend we're kind of just walking through the day room and that he says to me, hey, doctor, good to see you. I just came back to visit my nurses and my therapists because I'm doing so much better. And so this is actually Bob, who is somebody who's always delighted when I ask him if I can tell his story. He's always delighted to share his story. And he had quite a few issues that were risk factors for stroke, and he did have a stroke that affected the right side of his brain. And this is his attempt to draw a clock, which is a classic test for right brain function. The difficulty with it, it's a very small, I wouldn't use it as my only test because it's a very small thing. And people with spatial neglect, sometimes it has to be big, before they'll make errors. And also a clock is one of the few things that we draw where you're supposed to start on the right. And so sometimes people with spatial neglect can kind of work it out, and their symptoms are still evident when they do other things like get dressed and that kind of thing. But he had no hemianopia, so he didn't have a field cut when we tested his vision, but he had this thing called, he did not have something else called extinction to double simultaneous stimulation of visual stimuli. And what is that? It's a sign of unawareness in spatial neglect. Now, he didn't have it, but I'll just describe it briefly. Briefly, what you look for is whether if I'm looking at you, and this is here's my, let's say the hand that's on my right, on your right, and you can see that hand and you can see this hand, but when I do both, you only see the right one, the one on your right. That means that usually the capacity for perception in your right brain has been affected. So if you're able to see a single stimulus, but you're not able to see both simultaneously, that's very common. And obviously in real life, that can be very dangerous because when we're driving or something, we need to be able to see everything. But he did have this kind of leaning, this head and eye deviation. You can see it even here when we were first putting on glasses, about 10 to 20 degrees. And when he was marking the center of a line, he erred to the right. So here's a line, and this line is marked in the center, right? It's marked a little bit to the left of the center. And if any of you were fooled by this line, the real middle is just about here. If any of you were fooled, that's because your right brain is dominant for this task of marking the center of a line. And when the right brain is injured, what will happen is that you mark off to the right side, even if you're able to see over here perfectly. You'll start to make a misjudgment. And this wasn't Bob, but the person who did this had spatial neglect and also had unawareness. So he wrote that he was doing good when he did it. And that's a big challenge for stroke survivors and their families. So this is a person, again, with spatial neglect who had a lot of trouble with things like getting dressed, and he would not dress his body, for example, on the left. And he thought that he was doing just perfect. So this is a real issue because oftentimes families can feel kind of really overwhelmed and betrayed if their family member who's experiencing this problem doesn't agree that they're having a problem. But this happens in all kinds of brain disorders, and it even happens, as we're talking about psychiatry and neurology being very closely related specialties, happens in psychiatry too, where people don't feel that they have an issue. They don't feel that they need to take medication because they're not really having symptoms as far as they feel. And I think what we can talk about, and sometimes it's actually a useful way of putting things for even in our interactions with patients and families, is not just the phenomena. So we don't want to tell people, well, look at all these, how you did this line. Obviously you have a problem, because they're not, who would care about that? But we could talk about their function. So their activities of daily living, their ability to, don't you want to be able to get up and get dressed whenever you want to, rather than waiting for someone else to help you? Wouldn't you love to go bowling? You're a bowling champion. Would you like to drive again? And this is what's called the ICF, or the International Classification of Function, and it's part of the World Health Organization's way of tracking what's going on. And again, we have these phenomena, and that's very interesting. And my research was at first on phenomena. So the question was about, what was I interested in? I was interested in this turning behavior and the fact that we weren't measuring it. So I got very interested in that phenomenon, but then I realized, and what I've gotten very passionate about now, is that it really restricts people's activity and their participation. And even when people turn, Bob, who we saw before, tells me that one of the things that bothers him the most now is that he has difficulty when he's with his friends looking at his whole group of friends. And so he'll actually try to arrive at the restaurant first so that he can take a seat and be against a wall or in a booth so that his friends are all positioned so that he can easily turn and look at them. So you wouldn't necessarily think that the movement issue that we talked about or the turning issue would affect, socializing, but it does. It really does. So this is the end of my formal presentation, and it's a happy ending because Bob was one of the first people to receive Prism adaptation therapy, and that was through my research program, and now it's a clinical program. So here in Atlanta, for example, I've trained people at the Atlanta VA and also at Emory to deliver this treatment. We do it every day of the week with people who've had stroke. And he responded very well. He was able to return to being independent completely, to driving. But what I think is really awesome is that he not only returned to being self-independent, he was able to really return to a role. So that's participation. And he was able to be a son. And to be a son to your aging parents means helping them, right? So he was just so happy that he was able to be their caregiver when both of them were ill. And he was able, they lived in Delaware and he lives in New Jersey. And he was able to drive down and grocery shop for them and take them to doctor's appointments. And so really an excellent success story. Okay. I don't have a closing slide so we can look at Bob's smiling countenance. We have a little bit of time. Sorry, I didn't leave quite as much time as I intended to, but we have a little bit of time to talk about questions.
Absolutely. Well, first of all, thank you so much, Dr. Barrett. This was, like I mentioned from the beginning, a session that we're really looking forward to. And I'm sure a lot of people were not disappointed. This was such a great session. I loved seeing the cases and learning more about specifically neurorehabilitation. Hearing about subspecialties isn't something that many people get exposure to, but it's always great to hear. So for our first question, I wanted to just talk about exposure for students. And I usually like to ask this kind of question really for any field. As a student, shadowing is something that's there, but if they can get themselves more involved, what other pathways or what other opportunities can they take? Be that research, a more clinical, hands-on opportunity that you know of?
Well, really, I recommend that people just try a lot. It's like trying a job, really, right? So we just try a lot of different avenues and I think it's good. One of the qualities that always is a predictor of success is just being kind of persistent. And I don't mean persistent in pestering people, but not giving up. So if you don't find the right opportunity right away, just keep looking at different ones in different places. I mean, I think that what I did, for example, when I was a medical student, is I just went to, I had heard about this aphasiologist, Martha Sarno, and I just went to her office and left a note for her and said, is there any possible way that I could work with you? And I remember that she met with me and she said, well, I never work with medical students. And then about 3 months later, I was working with her in her laboratory. And eventually, I think she actually started paying me, which she didn't have to pay me because I would have worked for her for free because it was such a great experience. And that's what I did at first, is that she just gave me the opportunity to, I think she gave me the opportunity to sit in on some of the conversation groups for people who had stroke related communication problems. But I think she perceived my sincere desire to learn more about what was going on and to spend time with people and to see how her clinicians and researchers worked with patients. And I think that many people kind of understand that intuitively, that if we approach the opportunity to work with a clinician or a researcher with, just the idea, hey, can I just soak up some of this and can I just come, I don't want to be in your way. Can I come one day a week, or could I come one afternoon a week and sit in on some things? Or is there a way I could be of help? Can I do some of the tasks that some of the other people would be doing and free them up more to be with the patients? And, oftentimes we can impress people with that, because I think that something that's interesting is that the culture of working as a student, most of the undergraduates I work with still have the same attitude as they did when I was, even when I was in college. But some students, I think, really expect now more structure. And if we expect a lot of structure, that's work for the other person to do. And so, especially if you're asking a clinician or somebody who sees patients to provide structure for you and see their patients, that's maybe more than they can do. So if there's a way for you to bring your own structure and say, well, I'm wondering, even one can even go to one's own, former pediatrician or something, or former clinicians, or ask their advice. As you say, oh, I noticed that, you all do X on this day, and boy, I think maybe I could help with the blood. I could learn to take blood pressure, or I could learn to do this. And if you brought your own structure that way, that would be helpful. In research, of course, you wouldn't necessarily be bringing your own structure. However, if it's permitted, volunteering is always welcome. And there are many, you can kind of usually find out from your college. So for example, at Rutgers, there was a hematologist, immunologist, oncologist, oncologist. I think she's a basic scientist, Patricia Bocarsley, and Fitzgerald is, I think, the name she uses professionally. And she would have learners from even elementary school who would spend time in her lab, and she would just structure tasks for them because she loved to do that. So there are people who will gain the reputation in your if you ask around for making students welcome in their research lab, and such people are just gold. So even if you can just spend a little bit of time with them, it's a wonderful experience usually.
And really across all of the fields, not only is that, there are some things changing for better or for worse in fields, like you mentioned, the expectation of structure, but also technology is another one. Just like you mentioned, new medications coming out, and I think they even say every 5 or 10 years, our knowledge in medicine doubles, right, with research.
It feels that way.
Yeah, it does feel that way. So with that said, specifically in neurology, what are the biggest advances you've seen over your career?
Oh, no question. One of the reasons I'm interested in stroke is there's been so much advancement in that area. And most of the advancement, unfortunately, has been in the first 72 hours and not in the time that I see people. But it's just completely different now in the first 72 hours than it used to be, right? Some of the other areas of neurology that have really changed, certainly management of epilepsy has improved. The understanding of mind-body interaction has really improved in neurology, such that, we know that, if people are nervous, they'll develop a tremor. Well, other people, when they're nervous, actually develop symptoms, neurologic symptoms that can be very alarming, but that's a manifestation of their state. And that kind of problem is something that can be managed and lived with. But when I was in school, we weren't taught about that. And so we were like, oh no, is this, what is going on with this person? I may have mentioned epilepsy, so much better managed. Cognitive problems in general, I think there's a much better understanding, although I'm a little bit cynical about that because I still, my father-in-law, before he passed, he and I used to always say, well, I woke up this morning, there's still not a cure for dementia. So why not? We would really like to see dramatic changes. That was one of the reasons I got interested in Prism adaptation therapy, actually, because previously for things like neglect, there were kind of small changes we could make. And I think that's kind of unfortunately where we are with a lot of care for dementia once people have a lot of symptoms. But the understanding of the big thing, maybe we can, I can stop talking on this note, the therapeutic value of exercise and of, managing our lives in a healthy way, right? That's just so, it used to be doctors, when I was in training, doctors would smoke, doctors would never not take care of themselves. And now we see a completely different set of expectations. And it's really wonderful. That's actually a great reason, if any of you are thinking about it, if you're really invested in your own health, you might consider rehabilitation as well as neurology, and consider the VA, where there's all kinds of great physicians who will join with you. It's a really collaborative community, and one where people are always kind of, propping each other up. I think that more maybe than some of the other healthcare systems.
I actually wanted to just end off on one more question about settings. You've been to many states, many settings. There's, like you mentioned, the VA, there's academic medicine, There's also private practice, just to put that out there too. From your colleagues and your own experience, could you walk us through, especially for the students who might not necessarily have as much exposure to what those settings are, especially within the field of neurology, what they look like, how they accommodate patients, volume, and all that?
Wow, that's a big question, but I can kind of touch the surface. So the VA is a health system and it provides all levels of care. Neurology is one of its different specialty services. So the VA has all kinds of specialty services. It's kind of like, I mean, I hesitate to make this comparison because somebody's going to come for me, but it's kind of like, you know, medicine in Canada or something, or medicine in France, in some ways, because everybody who has access to the system in similar ways. In a separate way, in the private sector, like for example, a private practice neurologist, there are not as many solo practitioners anymore because of the burden of keeping your records and, you know, paying for all of that. But group practices exist where people just have, you know, whatever, 3,000 or 5,000 patients and among a group of neurologists, and they see them and follow them up. And they might have an affiliation with a hospital, but they're not necessarily teaching or doing research. And those people who are in a group, but also teach and do research, and then perhaps are salaried rather than being, you know, having their pay determined by their clinical revenue, are usually what we say academic neurologists. So they may be like at Emory or even in any system at Rutgers. Nowadays that model is changing a little bit so that, for example, you might have some people like that at Rutgers and then some other people who are in the community as private practitioners, but they come a few days a month and do some teaching and this kind of thing. I've also worked in a nonprofit organization as a neurologist, and plenty of neurologists work in industry, for example, and you can really have a great career in those settings. As I said, I was around, you know, lawyers and business people and donors. That was a real pleasure, actually, to understand why other people had dedicated their lives to helping people with neurological problems who were not themselves clinicians. So it was really wonderful to gain that understanding. At the same time, it's different. You know, your job is different. You're supposed to produce different kinds of things. So the goals of your work is different. And I think that's one of the things that as doctors we can change. We can work in different settings. And something I did want to mention about the VA that's great is that in the VA, if you kind of get, you know, as you said, I've worked in a lot of different states, and if you get tired of being in one place in the VA, you can transfer to another station in the VA and keep your role. You're not thought of as leaving your job and going away from the VA. You're still a VA physician. So I have a number of colleagues who, after, you know, 8 years, 10 years in one place, go to another VA in another part of the country, and it allows for a lot of flexibility, and you can keep all your benefits and all that stuff and your days off and keep the same email.
All right, well, I think that's a perfect place to wrap up today's session at. Thank you again so much, Dr. Barrett. It was really an honor for us to hear from your experience. Again, the specialty that we were really looking forward to. I have a few last reminders to our shadowers just before we close. So to those who have attended for today, and if you would like to earn credit for your attendance, just to do that, you must pass the quiz to receive a certificate. That quiz is now posted in 2 places, in our chat box and also on our website under the virtual shadowing page. The quiz will be due at 11:59 p.m. Central Standard Time this upcoming Wednesday, September 14th. So just be sure to complete it before then. And after passing that quiz with at least 6 out of those 10 questions or more correct, your certificate will be sent to the inbox, the email address that you list on the quiz. Just in case, let's say you don't find it in your inbox, please check your spam folder. And let's say it's not even there, we're happy to help you retrieve it. So no worries there. Just be sure to send us an email. Again, our email is shadowing.h@gmail.com. Next week, we're going to be on a 1-week break from shadowing, and we're going to resume on the following week on the 19th, again, with Monday and Thursday scheduled sessions. So just keep that in mind. Next week, we're going to have a week off from shadowing, and then we're going to resume thereafter into more so really the new fall semester shadowing sessions now that the semester has picked up for students. And on the 19th, we're going to be seeing Dr. Saha, who is the actual medical director of the University of Kentucky's PA program, and he directs their transition to practice and advanced training programs over there. So he's in quite a few leadership roles. Many of our speakers are in leadership roles, like Dr. Barrett, herself, and others. So it's really great to hear from them. If you have any speakers that you'd like to see, but you haven't seen so far with our sessions, feel free to put that in the Q&A, or not the Q&A, the questions blank at the very bottom of our quiz. We include just any feedback that you have from any sessions. You can feel free to list it there. So if you have any speakers in particular that you'd like to see, even if you have a certain speaker in mind that you know of, a certain physician that you've shadowed, it's really helpful for us to get to know either that specialty or that speaker's name, so that we can connect with them. So that's going to be, like I said, on September 19th, a Monday at, as always, 7 p.m. Central. And like I said at the beginning, if you want to stay tuned with us, either follow us on Instagram or subscribe to our listserv to keep an eye out for future shadowing sessions. We're planning to continue this through the end of this year, so stay tuned. But with all that said, I think that's all. Again, thank you so much, Dr. Barrett. It was an honor to have you here, and we will be seeing everyone on the 19th. All right, have a great night.